So I spent about a year there, and I've learned it from the masters at those time. So for me, the learning curve was not difficult. It was quite easy. So I find the coming generation, new generation, who wants to learn any new technique, they'll try to learn on workshop and cadaver workshop, or maybe in conferences. That's where the learning curve becomes very steep, actually. So if you want to learn any technology, in my mind, I think you spend time, at least for a couple of months, if not with somebody who is a high volume center and who's doing it regularly, then always the learning curve becomes very easy. The second thing is, compared to endoscopy and whatever the biportal, the learning curve in tube is very, very easy, actually. Because the medium is air, you're familiar with the open surgeries, and the second thing is, the vision is also 3D. You're using a microscope to see exactly the way you see in the open surgeries, right? So first you have to need to know that what's a tubular surgery. Tubular surgery is nothing but a small tubal tunnel. The vision is tunnel vision, but you're exactly seeing the same thing what you see in open surgery, right? So you have to orient yourself to the anatomy for the limited vision, okay? So these are the, and I also need to know the anatomy of the of decompressions, and when you are using TILI for extraforaminal decompression, you need to know where the docking point is. So my emphasis mainly is on anatomy. So well verse yourself with the anatomy, and then things will fall in line. Because the basic technique remains the same. You're using the same kind of equipment, what you use in open surgery. There's no fancy instruments. The only thing you need is a microscope and a drill. Okay, so you dilate him. Dr. Luhana has explained very well. So I just highlight a few points here. When you dock on if you're doing a discectomy, the best thing to start with discectomy L5, S1, or L4-5, you dock in, and what you see is the lamina, what you see in open surgery, right? So you see the lamina, you see the interlaminar space, and then you remove it. You remove it with the burr or the Kerrison punch, and what you see is the phlebum. That's exactly what you see in open surgeries. There's no difference, actually. It's just a mindset and the orientation of anatomy. And then you remove the phlebum, and you see the dura in front of you. So coming to the dilator, when you begin your cases, I think it's better to use a bigger dilator so you can actually see bigger, and it's much easier for you. When I started my practice, or when I trained, we're using 20 mm for decompression, 26 mm dilator for TILI. Now I've reduced to 14 and 18. If you're not very comfortable with the fixed dilator, you can use expandable dilator. So this is an example of the cases. So best cases to do first is the contained disc. And once you have done few contained discs, 5 or 6 cases, then you can jump on any kind of disc you have at 5S1. So this is a case which is sequential disc. It's very easy to dock there. Remember, just use a small tube. Once you have done 5, 6 cases, small tube, because if you use a bigger tube for the decompression, you always land on facet joints. So the important thing that the tube should fit the interlaminar space. And you take the lamina off, and you can remove the disc. The second most important thing is you need to learn the art of over-the-top decompression. It's very important. If you want to be a successful tubular surgeon, this is the must. Okay? Without this, you cannot proceed to do TILI for any complex cases. So for over-the-top, you can van the tube as you want. And I was listening to, for 2 days, like biportal and endoscopy. Here in tubular surgery, the main advantage over all these tubes is, incision is never a problem. Incision, a smaller incision, or incision which is once bigger than the tube, it's just not going to change your outcome. What's going to change your outcome is the ease of surgery and the minimum complication, the ease of doing the neural decompression and the completion of neural decompression. So what I divide into, when I do a decompression over the top, I divide the dura into 4 quadrants. I start from the first quadrant and go to the second quadrant, then decompress the ipsilateral nerve root, and then go to the base of the spinal process. Decompress the base of the spinal process, and then take the 4th quadrant and decompress the contralateral nerve root. So these are the various steps of the decompression. I'll just jump to a video, small video it is. Will show you how I do my decompressions. So this is a typical over-the-top decompressions. These are grade 4. If you see, this is the orientation is there. This is capsular. This is caudal. So I just first decompress the lamina, the superior lamina, and take the phlebum out. I use a curette very frequently, remove the phlebum. then decompress the lateral recess, and then I go on and then I go and bud the base of the spine and take out the dura, take out the nerve root on the side. After you have done a few cases of over the top, you can go the extrafemoral disc. And the questions, the first, Nandan actually presented cases where they have injury of the TP. So docking is very important, how you dock your, for the extrafemoral disc. Never dock on your TP. TP is the weakest bone actually. If you dock on the TP, it's going to break. So I always dock on the lateral aspect of the facet joint. So I dock in such a way that I see the top of the facet joint and the pars. Once you see the dock of the facet joint and pars, this is exactly where you dock. And then you come more laterally. So you can't dock on the TP. The most important is, in the extrafemoral disc, extrafemoral decompression is you need to see the superior TP. That's your landmark, and the pars. So when I dock on the facet joint, I go a little bit on superiorly. I try to actively look at the TP, superior TP, and then I take down the superior TP actually, and go into the inside, the medial to it. I use burr sometime. Initial case I used to burr a lot, but I don't burr at all. So I burr a little bit of pars and burr a little bit of facet, and then you tease the intertransverse ligament. Once you tease the intertransverse ligament, the nerve root is right there, and you can see it. Unlike in endoscopy, where sometimes you can do the injury to the nerve root because it's a blind procedure almost. But here you can see everything, and then I use my curette to tease off everything. You can see nerve root, and then you can, most of the time when the disc is bulging, the nerve root is migrated superiorly. You retract it and decompress it. So in a second you'll see it. Just bear with me for 1 second. So I'm teasing off the intertransverse ligament now. Cutting it, and then the nerve root is right in front of you. The important point is, do not use your diathermy here. Do not use at all. Because DRJ is very sensitive. Use a diathermy. You have to use very judiciously, and I will say that don't use it. If you have a bleeding, try to prevent it with the gel foam or another thing, Flowcell, and you see the disc is right there, and then you can take the disc out. Yeah. So next is so TLIF you can start before that. So the sequential dilation, I will skip the steps. So
Dr.
when
Baid,
I do
we are
TLIF,
out of time. Can you just
1 minute. So most important thing, you dock on the lateral facet always when you're doing TLIF, because otherwise you will in a soup. So because TLIF was described in the way that it prevent. It is advantage of a PLIF is that PLIF you need to retract dura a lot, okay, and then you have more complication of dural injury and the nerve root injuries. So that's why you have to dock on the facet joints. So I will not go to videos. A lot of videos are there. So I will just skip this and then say then you can graduate to revision surgery. This is a revision surgery which can be done using avoid the surgical scar, and this patient does very well. This patient was CKD patient on dialysis. Another patient, this doctor came to me 6 months back. He had a surgery somewhere, and then post-op has a cauda equina. The MRI shows that there was no decompression at all. So he's a Caesar grade 4 decompression stenosis, and this was a CT scan. So there are many ways I could have done, but what I decided to use a tube. I went inside the fusion mass and decompressed him completely. So this is the result. So I did the over-the-top decompression. You look at this post-op CT, I could able to decompress them. It took me about 3 hours to decompress 2 levels, but the patient's recovering now. So now that I am doing a lot of interbody fusion, dorsal spine for infection cases. I've done about 25 cases around. These were cases of patient who had a myocardial infarction on dual antillate platelet, and the anesthetist say we don't have time, I can't cause bleeding, so I did the MIS interbody fusion. This is the post-op MRI, so use a complete decompression. Patient came with the Asia B, and now he's Asia D now after 6 months. Another case which with infective discitis, same thing. I do a lot of my tuberculosis case with MIS tubular system. I also do a lot of OLF cases with
Yeah, Dr. Baid,
tube
can you
system.
conclude?
So now I've graduated to doing a lot of my metastasis, and majority of my metastasis and everything is tube. So I would say 90% of my cases I do just by tube, be it metastasis, be it fracture, be it compression, or be it anything. So I think tube is very, very versatile. You can use it to do anything what you want. Thank you.